The Catholic tradition, it often uses this expression that we respect life from the moment of conception. I'm not a scientist, but I have read that conception actually takes several hours, more than just a moment. So that phrase can be, I suppose, perhaps a little bit, maybe needs some more nuance. But I think the point is that the Catholic tradition wants to say, again, if in principle we respect human life, then how do we tell what qualifies as a human life? And the genetic marker of having a complete set of human DNA is seen as, the best marker we have. There is some question among, I guess you could say, commentators as to when the human soul comes to be. And if you read Catholic magisterial texts such as Donum Vitae and a more recent update, which is called Dignitas Personae, the magisterium does not claim to know exactly how the soul comes to be in us, but their stance is that because we would want to be erring on the side of caution when you're dealing with life or death questions involving what is a genetically human organism that is alive, that we would want to err on the side of protection. It's just, if you're trying to respect human life, that you would not want to take any risks that can be avoided. And so therefore the fact that we do have different research procedures or different drugs or certainly abortion that will end the life of an early human being that is alive. And the fact that it's alive, I mean, I once asked my science teachers in the school where I teach, is there a definition of being alive? And they're like, oh yes, here it is right here on this page of my textbook. It means that you have cell division and you're processing nutrients and you maintain homeostasis. And she rattled off a list of scientific characteristics for human life. So I think the question of whether something like an abortion or certain types of research on human embryos, the fact that they will damage or destroy a human life is not really the question. The question is whether that matters in a moral sense. And another way of putting that is that does the human life prior to birth count in the moral sense as a person? Because that word person is a word that designates a being that has value, a being that has rights, a being to whom we owe some kind of obligations. And so the Catholic tradition wants to say that although we don't know exactly how the soul comes to be, that we want to treat from conception or from fertilization or from the time the human genetic code is established, we want to treat this creature with protection, particularly because it can't protect itself. Now, there are different milestones along the developmental cycle of a human prior to birth that some ethicists have asked whether, for instance, the fact that up to a certain number of days, I want to say that it's about 2 weeks post-fertilization, the cells in this developing human embryo they're not assigned, they're undifferentiated, meaning if you've ever delivered a baby, you know this, that when you deliver a baby, you deliver the baby and the baby comes out and everyone claps and puts a hat on it and takes a picture and is all excited. And then a few minutes later, the placenta comes out and no one claps and no one puts a hat on it or takes its picture or hugs it. It's got the same human genetic code, but and it came from that same embryo, but it's not got the same personal status. So the question is, if we know that for the first very early period of the developmental process, that embryo has certain parts of it that are going to become the placenta, and that there are other parts that are going to become the child. Do we sort of say that entity has a different moral status and perhaps is not deserving of the same moral protection up until the point that those cells have their assigned jobs, and we can kind of say what part's going to become the baby and what part's going to become the other placenta and so forth. I guess, again, the Catholic tradition, and there's also concern about twinning. In other words, that up to a certain point in the gestation process, the embryo can split, right? And then you can get identical twins. And that can, my understanding is that can also be artificially provoked in a lab. So the question is, if you know that up to a certain point in the developmental process, there is the potential, at least, that you could end up with two persons rather than one person, does that mean that the prior entity did not really have the status of an individual yet that ought to be treated as a person? And I guess the Catholic tradition is asking us to, again, to err on the side of protection.
I recently hosted a conference at Princeton University along with Peter Singer, Francis Kisley, and Charles Camosi. And the purpose of the conference was to bring multi-views, so not just in a binary sense of pro-life and pro-choice, but all of the views on the topic of abortion together to dialogue on what some have said was potentially one of the first times in history. And not just bringing pro-life, pro-choice, and the gradualist positions together, but also academics, activists, philosophers, theologians, lawyers, clinicians, people who normally would never have an opportunity to sit down together and talk about the issue. So that was accomplishment number one. And the reason I think that this is so critical for Christian ethicists, or in general for humanity, is because if you do not reach across your own camps or your own families, so to speak, you have a lot of division. And when you have division on a topic, and you fail to see the other person the other individual as a person, but merely an argument to be won, or a culture of death, we use those terminologies, and we only see division, we break the bonds of a shared humanity. And that's a real problem for peace, for collaborative efforts on other social justices. So it was important to dialogue on the issue, one, because abortion is a critical life and death issue, but secondly, we absolutely have to not contribute to society with division.
One of the things I have found is with the new technologies where we can do ultrasounds and determine the sex of a fetus before they are born, in many situations, especially in third world countries, we are finding that many girl fetuses are being aborted precisely because they are girls. And so technology, while technology is neither good or bad in itself, we also need to think about how we are using these technologies and what purposes we are putting these technologies to.
Between your birth and your death, there's a whole other host of ethical questions and conditions that need to be met for a flourishing life. So one of those would be access to drugs, access to medicines, to healthcare, to treatments. And that's why I decided with Bioethics International to start working directly with the CEOs and scientists and all the executives involved in those major pharmaceutical companies, Pfizer, Merck, Johnson & Johnson, Eli Lilly's, and the smaller biotech firms as well. So first of all, a pharmaceutical company has to decide which drugs they're going to focus on in their research and development. So it's their research and development priorities. So for example, you can focus on large money makers like a Viagra, or you can also focus on, and not that they're mutually exclusive, smaller drugs that affect smaller populations, for example, in developing countries that people can't really pay for. So a company is left with an ethical question of, should we focus on those smaller disease drugs, unprofitable drugs, when people, they may not be well funded. And you have to remember, a pharmaceutical company needs profits in order to continue to sustainably innovate. Now, for some reason, society seems to be against large profits for pharmaceutical companies, and I think that that's partly justified, but we have to remember that profits are necessary for innovation. Innovation is a cold term for future cures and future treatments. So there's that balance to be found between profits for innovation and maximizing access domestically and then internationally, which is another question. So that's your first question. Which drugs do you make? The second question that naturally comes from that is, how do you price the drugs? Again, maximizing access, but also maximizing future cures and future treatments, innovation. Another question, so 40% of clinical trials are done in developing countries, a number that is only going up at this point. So in Africa, Egypt, China, India. So I recently was working on a case in Africa. How do you explain to a woman who's illiterate in a tribe where normally a husband or a tribal leader gives consent for a female who has very little access to healthcare outside of a clinical trial, who has no idea what a placebo is? How do you explain to her the clinical trial process that's going on and truly respect her freedom and get an informed consent? Another ethical question. Pharmaceutical ethics has been a need for a while, and I can just start in the 1930s. There's this very famous case, the Tuskegee case. So in 1930s, the US government wanted to learn about syphilis. So they ran a study, right? This is a study, it's what we still do. And they found 399 African Americans who had syphilis. They didn't know they had syphilis and they had never received any kind of treatment. And the study ran from the 30s through the 1970s. 1970s is not that long ago. So they put these 399 together. They run spinal taps at a series of points in time. In the 1940s, we develop what? Penicillin, which is a treatment for syphilis. They never give penicillin to the 399 African Americans. Why? Because they feel, under utilitarian metric, that it was justified to, in a sense, sacrifice the 399 minorities for the benefit of learning about syphilis and all the other thousands of people who have syphilis. That ends in the 1970s. And you would say that would never happen today, right? But if you fast forward to the 1990s, something similar happened with the Krieger lead paint study with a medical school associated with research. They wanted to see the effects of paint that has lead on children. So they have housing, I think it was in Baltimore, that they knew was painted with lead-based paint. They pay families to live in this, again, minority families, knowing that the children will be exposed to this risk, because they want to see what happens over time. And again, that would never happen now, right? Fast forward 2007, just a few years ago, and a company which will remain nameless decides to do a study on flu vaccine. And who do they recruit for their flu vaccine? But homeless and elderly patients that were pretty much alone in elderly care facilities. Again, vulnerable populations. And then in the late 90s, there was an AZT study that was done. AZT is a drug, AZT 760, that was supposed to cut the transmission of HIV from mothers to children, pregnant mothers to children. And so they found AZT 076, that it cut the transmission rate by 2/3. But they needed to find a cheaper version of it because it was $1,000 per pregnancy. It had a very complicated administration. So they tried to find a cheaper, faster, easier alternative. But in the clinical trial, instead of testing the new, quicker, cheaper, easier drug against the existing AZT therapy, they tested against a placebo. So you have a mother who is definitely HIV pregnant, you have a child at risk, and instead of testing against a drug you know works, they give the mother nothing, a sugar pill. And so there's reasons for doing that, pro arguments and con arguments. Some is that they said if we had tested against the existing treatment, the shorter, quicker, cheaper one wouldn't have looked as effective, and there's no way that the UN, for example, would say it was okay to give a slightly less effective drug because it's cheaper. So there's all these reasonings, but the fact is you need a standard process out there for thinking through these things. You get a standard of quality of care, of respect for human rights, and promotion of public health no matter where you live. So in that sense, I felt very strongly that we needed to start developing those global ethical standards. And I put together a council called the World Council for Ethical Standards. And on that council sit the executives from the major pharmaceutical companies. We meet biannually, and we're co-drafting these ethical standards and inviting companies to voluntarily show their demonstration, their commitment to excellence in ethics, and adopt the standards to protect and promote equality for everyone, which is basically human dignity in action.
Mark Maurer is a criminologist who works for the Sentencing Project in Washington, D.C. And in one of his books, Race to Incarcerate, he talks about imagining a birthing class, a Lamaze class. You have 9 mothers come into it, and they're all white. And the birthing coach begins talking to them about the joys of parenthood, things that they should expect, perhaps some problems that they could foresee in their children's future, and then says, and 3 of the 9 of you, your children will go to prison. We would be up in arms in our society if that were the case. But that doesn't happen. Yet 3 in 9 young African American males born in 2000 are likely to end up in prison or jail at some point in their future. And I think we're comfortable with that in our society. We're with ignoring the people that we're willing to throw away.
I am concerned, again, probably because I am a woman, about reproductive issues. I'm concerned about giving birth. I'm concerned about caring for people after they are born. I'm concerned about caring for people when they become disabled, when they are in the dying process. And I'm concerned about justice, making sure that the resources are there for people who do this caregiving activity.